right, very good. Let's see. So I see the participants trickling in, so I'll wait just a moment before we begin the introductions.
Okay. I think you had maybe 70 registrants.
Yep, 70. There's 34 have already have gotten on so far. I was just giving
okay. We can't see that set apparently.
If down on the bottom, it's you can see them. There's a participants list and they're beginning to trickle on.
Oh, there you go. Look at that. Okay.
Yeah. All right, just like we always do for any academic presentation, always give a couple minutes just to let people settle in.
So the Harvard version of that was nobody would ever come to the lecture room until about 7 minutes past. And when I was in university, if the prof hadn't showed up by 7 minutes, you were excused the hour. That's how long ago it was, and so far away. But when I got to Harvard, it was very hard for me to really put up with the fact that nobody showed up, and they showed up with Starbucks in their hand at 7 minutes. So I figured they spent the last 7 minutes, instead of sitting listening to me, at the Starbucks. And I was thinking, not very validating, as they say. But I got over it.
Our kill time was 15 minutes at MIT. That was when we kind of called it. And so I guess all right. Well, I think, let's see, we're at least over half the registrants are in. So I think we can begin things. So welcome. This is the next session of the Brachytherapy Everything Everywhere All at Once series. This one is focusing on cardiac brachytherapy or intravascular brachytherapy and the management of vascular stenosis and integration of care with interventional radiology. I just want to remind all the folks who are signing on that we're in registration renewal season for the ABS. So if you haven't already, please take care of your registration renewal, your membership renewal. And also, exciting for everybody, there's conference registration next week, the 2023 American Brachytherapy Society's annual meeting. It's going to be June 22nd through June 24th at the JW Marriott in Vancouver, British Columbia. Beautiful city. Should be a absolutely fantastic kind of series of talks and opportunities to reconnect. So with all of your brachytherapy colleagues from around the globe. The annual meeting is designed around the theme, delivering the right care for everyone, advancing brachytherapy access for all. And so I hope to see a lot of you there in person. And so, because I think it's going to be a very kind of an exciting agenda with lots of exciting activities and just kind of seeing what's going on in the world of brachytherapy. So I think we are ready to kind of start to kick things off here. So leading this discussion and providing perspective where brachytherapy fits, or cardiac brachytherapy fits in our armamentarium, is Dr. Philip Devlin. So while he needs no introduction, I'm going to introduce him anyway. And so he's the chief of the Division of Brachytherapy at the Dana-Farber Brigham, an institute physician and an associate professor at Harvard Medical School. He trained at UPenn and his fellowship at one of my alma maters, Sloan Kettering, and he's a fellow of the ABS. And he is an absolutely unparalleled expert in basically all things brachytherapy from head to toe. So he's going to, kick off the session, and hopefully everyone really enjoys all that we're going to bring for you today.
Well, good morning, good day, wherever you are. I'm just going to share my screen with you, if it'll let me. There we go. I'm looking for the window. There it is. Too many windows. Can you see that, Mike?
Yep, it is up.
Okay, and I'm just going to make it into a slideshow. Okay, and you can see that's the full screen.
Yep,
well, it's absolutely delightful that I got invited to be a part of this. I love the ABS, and I love the that I have been so privileged in my life to be a part of this down all these years. And hats off to all of you who are so focused and dedicated to take an hour out of this incredibly busy Tuesday to come and think on the edge of radiation oncology. First of all, a disclosure. I still get residuum from the Brachytherapy textbook, and I'm looking just that it's deployed, redeployed for good purposes. I want to also, as I do in every lecture in these last 2 years, remember Larissa Lee. Larissa Lee was very much a member of my faculty who died at 44 years of age of metastatic colorectal cancer. And she is such a champion of brachytherapy, not just for the gynecological brachytherapy of her own passion, but also for that of the entire enterprise, and came up under tutelage here. And she is missed. We've replaced her with bright young people, but are holding her in our hearts always, and always remembering her. And just to show that she has a context other than brachytherapy, these two lovely boys and a lovely husband are very much part of our family still. So last year I went viral with, from head to toe, there ain't no place brachy don't go. Okay, so you got it. That's the jingle of the day here, no matter what the cardiologist tells you. Anyway, so let's just focus simply that brachytherapy is the clinical use of radioactive sources to deliver the highly conformal radiation therapy to complicated targets. Greek, brachios, therapeutikos. It's distinguished from what we do 99% of radiation therapy, which is called teletherapy or telos therapeuticos, long therapy. That's really important. We need to know how small brachytherapy is in the big context of our lives as radiation oncologists. So there ain't no place that brachy can't go. And we have been in the ABS expanding the scope of this practice to respond to unmet need. What do? We have quality issues. We have peer review. We prospectively validate. We test and retest in evolving settings, and that matters right here. We use image guidance. We look at sequencing a therapy for maximum effect and minimum side effect. And we're looking at the interactions of novel biologics and immunotherapy in pretty much everything we do. You know, that's oncology. Brachytherapy is for complex targets, both superficial and deep. A simple target is something that's flat and is easily done with, say, an electron beam therapy. Complicated targets are wicked complicated with funky shapes and interesting issues and things like organs at risk within millimeters. Those are our complicated targets. That's where brachytherapy pulls the rabbit out of the hat. So, again, to contextualize, we'll get to the bottom, vascular, but there are 3 Gs of brachytherapy: gynecological care, randomized data, global data, wonderful data that shows if we do it right, we do it in sequence, we do it with the right chemotherapy, we save people who would otherwise die. Genitourinary brachytherapy is focused mostly on prostate. There are a few other areas, and the rest of it is the general practice of brachytherapy. Although I've mentioned 8 disease sites there before vascular, at this time, skin, GI, and vascular predominate. Things may change, and so we're available to do all of those. So vascular happens to show up as a pretty small little part of what we do in the great, great scheme of the radiation oncology, the radiation therapy enterprise. And so as we go out of it to meet the rest of the world, we're sort of like, we're coming to a corner of our practice and not to the center of the practice. You know, a way to look at this is that this is a frontier for radiation therapy in general. And these other areas are here, but we will think about both femoral artery, coronary artery, vein grafts, and this idea about where we started with the cardiologists in the 90s, which is single layer, short, bare, metal stent, in-stent restenosis, and then come back to where we are now, multiple layers, long lesions, drug-eluting stent resistant, and that is really what we need to do to advance the frontier, continue to do to advance the frontier. I brought you something you think is irrelevant. This is a good old-fashioned dumbbell keloid on a wonderful, wonderful gentleman in our community. This thing is ugly and painful and growing like mushroom caps. So why does that matter for coronary brachytherapy? If you just resect it, it grows back again. If you resect it, it grows back again. If you dilate a balloon, it grows back again. They're both the same thing, an immune-mediated inflammatory process that we arrest by doing immediate postoperative radiation therapy. Just to show you how to do that, if you haven't known, you can do it with this beautiful dose distribution of image guidance, computer optimization, and gorgeous attention to detail and shielding. More about that when I see you all in June. But just to say that we have a habit of treating not only cancerous diseases, but benign diseases. And as it happens, the biology of the benign disease called keloid is remarkably similar to the biology of the disease called in-stent restenosis, etc. Okay, I want to wrap this because I'm just the warm-up show for the heavy hitters who are coming on here. But what I want to wrap it up is Philip Devlin's brief history with coronary artery radiation therapy. Okay. So I show up as an attending after a fellowship in the mid-90s. Wet behind the ears and greenhorn though I was. And they were in the middle of doing these wonderful trials. The Scripps trial had happened, the START 2030, the START 2040, the RISK, the this, the that, the next thing. All of these trials, you may hear about some of them now. And we were absolutely involved in it with the group that was here during that time. And I mentioned two people. One is Jeff Popma, who's still the chief at the Beth Israel across, a wonderful colleague and friend who he mentored me, and we flew all around the world telling people how to do this stuff. And Don Bain, the great father, who I'll mention in just a minute. But there was a fateful day, and I think it was May 2003, where there were, maybe in the same copy of the New England Journal, two randomized trials, one for Taxus and one for sirolimus. And they said 40% restenosis goes down to 0 or something like that. And then, absolutely, as if out of central casting, Dr. Popma walks into the cath lab and says, "Thank you, Philip, goodbye." And in an instant, we drop-kicked brachytherapy for coronary arteries out of existence. The corporation went bust. People lost some money who gambled on it. And it was just like the FDA couldn't have shut us down quicker than those two articles. Okay, that's just my view. Please disagree eventually. Anyway, the radiation oncologists, to tell you the truth, we were ambivalent. One, we thought it was a good therapy. But two, gosh, gee, hanging out with those, the difference in the culture, the difference between, John Wayne strides into the cath lab and boldly opens the thing and saves a life, to this little quiet church mouse sort of thing called a radiation oncologist. Very different culture. And it was hard to get those cultures together. Anyway, by 2006, we start seeing that 0 was not durable all the time. And so there was this time to say, would you, could you, should you? And by 2008, we were asked, can you get back in and work with it? And so with many groups around the country, maybe 20 groups around the country, we said, we will come back. But let's look at what's the difference between the early people and the late people. The trials were initially done on a single 20-millimeter lesion with bare metal stents at first failure. The 40% restenosis dropped down to about 11. They were different at every trial, of course. And the biological environment was a hypercellular intimal hyperplasia. There was, because you only had one stent somewhere, usually a cabbage salvage if you needed it. So that was the biology we walked away from on that rainy day in May 2003. We show up again 2008 or so. Now look, what's happened is the answer to a drug-eluting stent failure is put another stent in. It's a great answer. It's the standard of care. They were long lesions. There were many, or multiple, often 2, sometimes 3. We saw 5 here one day, honest to God. There were many concurrent problems. There were poor stent deployment issues, stent fracture issues, which there always were, by the way. There was extra calcium. There was a hypocellular intimal hyperplasia, different biology to the hypercellular. There was no cabbage salvage, and we estimate that the national thing was about 100,000 of those people per year. I'm going to share my own personal unpublished thoughts and impression of non-surgical cases with multiple PCIs and multiple layers of drug-eluting stents and an alarming recurrence of in-stent restenosis despite excellent care. What I like to say is there is 100% chance of subsequent ISR with just PCI. Stent redeployment, pulsed contrast laser, shockwave road ablation, shockwaves, road ablation, and brachytherapy has shown in our hands that 100% restenosis can be as low as 25% subsequent restenosis. We have not published that. I'm calling it an unpublished thought and an impression. Love to hear what you think. So this is what obviously what it looks like. We don't need to focus on that. I haven't brought much about peripheral arteries. As we know, there are 6 randomized trials and a pilot, which also say the same thing for bare metal stents with high-dose brachytherapy. So we've told you all about that already. And I want to ask one final question to us all. We have ongoing trials with drug-eluting balloons. Will cardiology throw brachytherapy aside again in 2003, 20 years later after we got thrown the last time? Or is there room to integrate brachytherapy in as we go forward with drug and radiation in the care of complex coronary artery disease? Thank you.
Excellent. And so we'll be coming back to some of those questions towards the end when we have a little bit of a roundtable discussion. But just as Dr. Devlin has said, we're going to be kicking off the next part where the Yale team is going to be discussing, they'll be expanding further on coronary brachytherapy and their approach to starting and building a program, the clinical workflow on the radiation interventional side, patient management, and issues that can arise on treatment, touch on where the field is going. And we're going to be starting off with Dr. Kenneth Roberts, who is a professor of therapeutic radiology at the Yale School of Medicine. He's the chief of the cardiac brachytherapy program, among many other responsibilities that he has there, including pediatrics, lymphoma, sarcoma, and proton therapy. So he keeps himself quite busy. And besides being a fellow MIT alum, he's fellowship trained in hematology, oncology, and radiation oncology through Duke before moving to Yale. So he's going to be then kicking off next with his presentation on coronary brachytherapy. So go ahead and take it away.
Yes, thanks, Mike, and thanks for the great introduction, Philip. Always love to get a lesson in Attic Greek and hear the history of our field and your wealth of experience. And you're going to be hearing from myself, Steve Pfau, who's our key interventional cardiologist in our program, and Dehan, who's our medical physicist involved with our program. Anyway, this is sort of a broad outline of what I'm going to be discussing. But so I'll gloss over what in-stent restenosis is all about. But it is the keloid of coronary artery disease, and there's a process of intimal hyperplasia that, despite angioplasty and stenting, there's a recurrent obstruction, not from atherosclerosis, but from this chronic inflammatory milieu causing this fibrous, invasive process. Stents, just to give you a visual picture, the size of a dime. And angiographically, this is a focal example of in-stent restenosis, probably dating back to our bare metal stent era in the right coronary artery. And on cross-sectional imaging with ultrasound, you get a picture like this, showing the stent material and this proliferative growth of fibroblasts. And histologically, it looks something like this. Patients who are at high risk have diabetes, long lesions, narrow vessels. Vein grafts are more prone to in-stent restenosis. for unclear reasons, renal failure is a predisposition. But the major, issue is that some patients are biologically predisposed, and if you have prior in-stent restenosis, you are at higher risk for this occurring. If you have stent-in-stent recurrent in-stenosis, yes, it does approach 100%, as Philip indicated for our current patients we see in the cath lab. I'll just skip over that. So, epidemiologically, this still is a huge problem in the practice of interventional cardiologists. There's close to 1 million PCIs that are performed annually in the United States. Majority end up with drug-eluting stents, and yet our current experience is that in-stent restenosis is still a significant clinical problem occurring in 10% of patients, 2/3 of whom usually get, post-DES in-stent restenosis. Again, we, as radiation oncologists, we're used to treating a variety of proliferative disorders with radiation, and keloids is the arch example. Delivering 10 to 30 gray to the vascular adventitia is what we think is required for effective brachytherapy. And there is, this is a field that has a plethora of randomized trials in the bare metal stent era, highly regulated by the FDA. And there were 3 different devices that were approved using different catheter designs, different radioisotopes. And this is just a summary of 5 of the major trials using different radioisotopes, all of which were consistent in showing a significant reduction in in-stent restenosis. And in this early period of investigations, patients used to come back for angiographic follow-up, to assess and prove that our radiotherapy was effective. Not a standard clinical practice now. Patients who come back have clinical problems, but there is a solid scientific basis for what we're doing with brachytherapy. The START trial forms the basis of our practice now. When the dust settled with the introduction of drug-eluting stents, only the company Novost remained commercially viable and is the only source of brachytherapy devices in the United States. It's a strontium-90 source. Based on the prior trial, the START trial, we predominantly still use the FDA-labeled prescription rules. And it was purposely kept simple. We deliver based on the diameter of the blood vessel that we're targeting, either 18.4 or 23 gray at a 2 millimeter depth. The early experience was based on angiographic assessment of what the diameter is, but now modern practice in the cath lab, and Steve Fow, I'm sure, will emphasize this, high quality practice utilizes cross-sectional imaging of the coronary vessels to guide decisions about all the full armamentarium in the cath lab with percutaneous coronary interventions, which includes brachytherapy. The BetaCath device is a hydraulic delivery system. It was kind of envisioned to be something that the cardiologist would be very comfortable with. And it's actually a very well-designed device in that regard. Wanted to emphasize the dosimetry. The dose fall off from a single linear array of radiation sources used in intravascular brachytherapy has a very sharp drop off in dose, as I think all radiation oncologists appreciate. The 2 extremes are, I guess, iridium, less fall off versus P32, and strontium-90 falls in the middle. There are definite dosimetry issues with non-centering of the source array. So, and that, happens more frequently than we desire. Ideally, you'd want to have the source train right in the middle of the vessel, but the beta cath device isn't designed to have a centering catheter. So there's a lot of variability in the dose being delivered in the catheter. The other thing that we all understand but don't really model in our dosimetry is that the effect of stents and calcifications, high Z materials, are going to cause perturbations and reduction in dose delivery. This has been modeled. There's some definite shadowing effects, but we have to bear in mind that to a certain degree, this is a pitfall with the dosimetry. And I think clinically, as you're in the cath lab, looking at cross-sectional imaging from either ultrasound or optical coherence tomography, and this is an OCT image, just superimposing the dose distribution. We prescribe to 2 millimeter depth, but as you go to 3 millimeters, the dose you're delivering is about 50%. 4 millimeters, it's about 22%. And that's important to recognize when you're actually taking care of patients in real time. I wanted to also spend a little time showing why dosimetry is important. Back in our bare metal stent era, we did have this very nice dosimetry study out of a cohort of 140 patients who had good angiographic and clinical follow-up. We were able to call out only 14 cases that had good IVUS imaging that showed the external elastic membrane well, because we wanted to study the delivery of dose to the adventitia. And we did some very elegant reconstruction of the dosimetry based on the IVUS imaging, and did a nested case control study matching therapy characteristics. And we measured this parameter dose to 90% of the adventitia, looking at minimum, average, maximal dose. This graph shows a particular patient example. But when we did our case control study, we sorted out that success versus failure was predicated on the dose delivered. And we found out that there was a threshold dose of 8.4, minimum dose of 8.4 gray to the adventitia, the external elastic membrane, if you will, that predicted for treatment success. And I think that's another important concept to just remember as you take care of these patients. We found in our study and our ongoing practice, there's a wide variation in dose delivered. We don't, with our current very simplistic brachytherapy rules, don't adequately account for the underdosing that goes on because of non-centering and high Z material. But there may well be a dose threshold that we should be paying attention to. And anyway, since drug-eluting stents have been introduced into interventional coronary cardiology practice, I wanted to highlight two studies that still demonstrate the efficacy of what we do with brachytherapy. Mount Sinai published, I think it was 2019, their retrospective review of patients who had drug-eluting stent restenosis, and they compared patients who got brachytherapy in addition to the other interventions versus those who did not get brachytherapy. And they demonstrated statistically, as well as with a propensity score matched cohort, that there was a clear reduction in important clinical endpoints using brachytherapy. So Cleveland Clinic also has published their recent experience, And what's interesting with their experience is that they made a policy decision back in 2015 to increase the radiation dose being delivered. So initially they were following the FDA labeling for the beta-cath device, but then they decided to increase the dose based on vessel diameter, either to 23 gray or 25 gray at a 2 millimeter prescription depth. And in their analysis of their series of 330 patients, two findings that I think are of interest are, number one, the number of stents in the lesion being irradiated is a factor, prognostic factor in the risk of additional future in-stent restenosis despite brachytherapy. So more stents, higher risk. And maybe that's a function of, more perturbations of the dose being delivered, or maybe just a biology problem when it's not clear. But when they also looked at the effect of increasing the radiation dose, there was a suggestion that maybe there were better outcomes, at least at 1 year follow-up, but not at 3 years, to increasing the radiation dose. So interesting finding, and the fact that we need to maybe pay more attention to dosimetry. Now with our Yale program, typical, I think in the bare metal stent era, I think we're over 150 centers doing brachytherapy. And, we were one of the active groups. I think Philip kind of already indicated the history here. But we got into the business in early 2001. We were involved in some of the early clinical trials. We were fortunate we got hospital funding for this, which is probably non-existent at any medical center these days. But we also recognized that drug-eluting stents were being developed, and we knew that our brachytherapy program would be an important bridge until that came along. We're a monthly census of cases, was steadily increasing as we got more experience. Drug-eluting stents came along, and then a precipitous fall in our collaboration. So we, accumulated our own experience of 475 cases before drug-eluting stents. Our program disappeared, and then I got this very kind call from Steve Thau back in 2018, please come back. And we did. And so to date, we're almost up to about 200 cases. These are more complex coronary artery disease patients now, stent and stent, long lesions. And I'm sure Steve will talk about his impression. When we rejuvenated our program, working with Novos, we elected to lease both the 40 and 60 millimeter beta-cath systems. They also have a 30, but we see no need for that for very short lesions, which are uncommon. Logistically, the hospital, the cath lab stocks the individual treatment catheter kits based on our anticipated treatment volume. My impression is that this is not a high reimbursement field, but in a center such as Yale and many other academic centers, this is an important service to the complex cardiology interventional cardiology cases. I think having this unique service in the cath labs helps to attract patients from our region, and is important for building the overall interventional cardiology program. Novos has been an excellent partner with delivering systems, exchanging sources every 6 months. Dehan will talk a little bit more about the QA and the importance of the physics backup for this whole program. It is totally critical. We manage all of our cases electively. There's no such thing as a emergency brachytherapy case. They're scheduled several days in advance. I, as a radiation oncologist, can look at the patient's chart and review things ahead of time, but we do a same-day consultation in the prep hold area of the cath lab that same day. If they're inpatients, we see them, 1 or 2 days ahead of time. But we have an excellent working relationship with Steve and his other cardiologists, very comfortable with brachytherapy, and we all are in basically the same, we do a mind meld basically about which patients are going to benefit, and it's a very smooth and very nice collaboration. So this is the cath lab environment. This is normally the number of cardiologists working with a patient, and then you bring in the the radiation oncologist, the medical physicist, all the trainees at a place like Yale. There's a huge crowd hovering around the patient for these cases. And it takes time, extra time in the cath lab. So there's got to be a commitment on the side of the cardiologist that this is important, and we think it is. So I guess with that, I'm going to just let Steve take over because I've probably been rambling enough here. Yeah, I'll let Steve have you take over now.
Well, here, let me quickly introduce. And so this is Dr. Fowle. He's joining us also from Yale. He's a professor of clinical medicine at the Yale School of Medicine. He's the cardiology section chief for the VA Connecticut West Haven VA Medical Center. He trained at Presbyterian University Hospital in Pittsburgh, then completed his fellowship at Yale, where he is now. And he's a fellow of the American College of Cardiology and the Society for Cardiovascular Angiography and Intervention. And so he's going to be taking over now.
Thank you, Dr. Folker. Can you see my screen okay here?
We can see it, it's just not maxed up yet. There we go.
There we go. All right, thank you. And thanks, Ken, for that introduction. I just want to echo Ken's sentiment that we've had a very long history together. I noticed that Dr. Devlin's interventional cardiology partners have moved on, but Ken and I have been together since the beginning. So we work very well together, and he's been a real pleasure to work with all these years. So I'm going to step through our kind of interventional workflow process for you and have a few words about case selection and then go through a case step by step. So it all starts for us with the angiogram. This is a case of somebody who in the September of 22 had this very severe stenosis at the beginning of the circumflex, the ostium circumflex. And then that was treated with a stent from left main into circumflex here. And you can see that stenosis is gone. And within 6 months in February came back, and that stent is pretty well narrowed with a lot of intimal hyperplasia tissue. And so this is one of the cases that was referred to us recently. So, we have a number of referring centers within the Yale system spanning the state of Connecticut from New London to Greenwich. And all of those Yale hospitals understand the need for brachytherapy and give us a call and let us know. We can review those angiograms in real time with them. But we also have a pretty large distribution of non-Yale network hospitals who are familiar with our work over the 20 years that we've been doing this. And some of our former trainees are in these locations. And so without any real formal web presence or any advertising through word of mouth, we kind of capture a lot of patients throughout the state. And we even have had referrals from as far away as Albany. So that's our referral center, and it all starts with the angiogram. And once they have restenosis, they kind of reach out to us. We have 3 interventionalists on our faculty who have participated in the brachytherapy program. And one of the three of us is almost always available to jump on the computer and look at the angiogram and talk to the referring physician. Almost always, these cases are two failed prior stenting procedures with clinical angina ischemia and no other reasonable treatment option as outlined by Dr. Devlin. The old days, cabbage was always an option, but these days, surgery is rarely a good option for these patients, and that's why they are referred to us. So this is our kind of algorithm, how we think of it. If it's a first episode of restenosis, the data is pretty strong that another layer of stent is the best option. If you look at randomized trials of restenting versus drug-coated balloons or restenting versus brachytherapy, restenting wins. And so our recommendation in general is that if it's a first episode of restenosis, we would recommend a repeat drug-eluting stent. If not, if they already have had 2 layers of stenting, then that kind of falls into a category of patients that we're going to consider. The other important thing that's we consider is the time since their last procedure. So in general, if it's less than a year since their last angioplasty procedure, those are the ones who the data would support brachytherapy is best for. If it's been more than a year since their last angioplasty, that's a more heterogeneous group of patients. And I'll show you why I say that in a later slide, but that's where I think we have some work to do in terms of understanding if those patients who present late after stenting will benefit the most from brachytherapy or not. Clearly, those patients who come back quickly after their most recent procedure, we have great data, and those are the patients who benefit the most. And this kind of algorithm, the slide probably doesn't project that well, but this is just kind of, in general, the American College of Cardiology kind of favors this treatment algorithm to, 1 layers of stents goes for another drug-eluting stent procedure. And if not, then we want to steer away from a third stenting procedure. So let me just step you through a case. This is a 76-year-old male who we saw last year, multiple stenting procedures to his right coronary artery. At the time we saw him, his most recent procedure had been 6 months ago, and he came in through the ER with recurrent chest discomfort, which was typical of his angina symptoms. This is his angiogram, and you can appreciate that both proximally there's severe stenosis, and then more distally there is disease as well. And I think on my next slide, I just have a frame. You can see there's stents that go all the way from stem to stern in this right coronary artery, which you hopefully can appreciate there on this single radiographic image. And then if we just look at a freeze from his angiogram, you see the 2 areas that we're interested in here very proximally, and then there's another area of severe stenosis distally. So this is going to be a very long area to treat, and by intravascular imaging, we know there's a lot of disease through the mid part of this artery as well. So if we look by cross-sectional imaging, this is an intravascular ultrasound. The catheter is this blank circle here. The stent, you can see the bright white reflective metal of the stent out here at the edge. And then this kind of layered material here is the intimal hyperplasia, which is causing the symptoms, and is the scar tissue or restenotic tissue that is the real issue. In this particular case, we use laser atherectomy, a 1.7 millimeter excimer laser catheter to try to debulk some of that tissue. Because it's constrained by the stent, it's really hard to balloon it and move it out of the way. And so very often, practically speaking, you need to do something to ablate that tissue, either rotational atherectomy or in this case, laser atherectomy. And then we used balloons distally and then balloons proximally to try to open the lumen as much as we can. And if we repeat our cross-sectional imaging now, you see that there's just a little rim of new intimal tissue around the edge. This area is now the lumen. with our ultrasound catheter. I think this is also a good demonstration of what Dr. Roberts was discussing as the non-centering. Clearly, we assume that the brachytherapy catheter delivery device is going to lay in the same configuration as the ultrasound. So in this case, the sources would be much closer to this side of the artery and much farther away from the target, this side of the artery. These are 1 millimeter marks, and you can see that if we do our dose prescription at 2 millimeters, clearly we'll get into the wall of the artery here. But on this side, we're just barely reaching the edge of the lumen. And if you come out here at 4 or 5 o'clock, we're probably within the lumen of the artery still with our 2 millimeter dose prescription. We can use these cross-sectional images to do measurements. Here is a little bit more centered, but you can see that the diameters are 3.0 millimeters and 3.5 millimeters. These images can also be displayed longitudinally, as you can see here, where we can measure distances to decide, what source length we're going to have to use to treat. So intravascular imaging, whether it's ultrasound or OCT, is critical to how we decide to treat, and then our dose prescription and length of treated segment. So this is the delivery catheter in place. We use this to kind of gauge our position. This is the live video. And then if I stop it and just show you a single freeze, you can see the delivery catheter has several marks that show you the distances. So this is the end of where the sources will be. This is 30 millimeters, 40 mils, and 60 millimeters. So you can use this delivery catheter to kind of position and decide what your length of treatment is going to be. This is the sources that have been placed through the delivery catheter in the first position in this very long lesion. And then if I show you a single frame, you can see there's a radiopaque marker at the proximal end of the sources, a radiopaque marker at the distal end of the sources. And so the sources are here through this segment of the artery. And the worst of the treatment was, the worst of the stenosis was right here at this spot. And once the sources go in, we all stand around and talk about the weather or sports or whatever we can. So this is Dr. Roberts and one of the radiation therapy residents. This is an interventional cardiology fellow. This is Dr. Chimay, who's our expert in intracoronary imaging, who helps us with the OCT and IVUS interpretation. And I have nothing to do at all here, except find ways to strike up conversation. Then we reposition the catheter by pullback. So this is a little bit of a off the cuff eyeball. We kind of know where our proximal source position was, and now we're going to make that the distal source position, try not to overlap too much. It's not very precise. We can inject contrast and use side branches as fiduciary markers to try to make sure we're not overlapped too much. This is a still frame, and now you can see that the distal source it starts here, and proximally we end in the guiding catheter because we want to treat the entire length of the artery all the way to the aorta. So this is the second position, and here we are in our 4.5 or 5 minute delay of game penalty here while we're waiting for that to be treated. And then this is kind of the final result here. And in this particular patient, we know that he's now 10 months since his procedure, and he's not had any recurrent symptoms at this time. So just to spend a little time to comment on drug-coated balloons. So drug-coated balloons are a balloon that has an anti-neoplastic agent coating the surface. It comes with an elution carrier molecule, which comes off the balloon. They're widely available in Europe for both peripheral arterial disease, but also coronary disease. They're only approved in the US for peripheral disease right now, although the coronary trials are underway. And the question is, will it compete with brachytherapy? And I think that's a fair question. Certainly in Europe, I'm not aware that there's very much use of brachytherapy, if at all, but most commonly recurrent stenosis is treated with drug-eluting balloons or drug-coated balloons. I think a huge jump forward in our understanding of this has been optical coherence tomography. And if you look at panel A, the stent is obvious here with a bright white with a shadow. And the neointima is very homogeneous. And this is kind of new in-stent restenosis. It's cellular with a lot of extracellular matrix. And it's a very distinct pattern. And this is the type of restenosis we treated all the time in the early 2000s. But since OCT has come on board, we've understood that there are other patterns. There's this so-called layered pattern, where there's a lot of lipid very close to the surface, and then a more homogeneous neointima below it. There's this really bright stripe with shadowing, which represents a lot of lipid-filled macrophages here, which is on this side of the image, but still within a stent. This is actually somebody who presented with acute onset chest pain and a small myocardial infarction, and there's actually a rupture in their neointima here. And then this image actually represents calcium, which has been laid down inside the stent, believe it or not. So this is calcified plaque within a stent, and that process takes much longer than 6 months or a year. So this is type of in-stent stenosis presents later, but clearly presents a different kind of biology to us, a different kind of plaque to treat, to kind of enlarge this lumen, and may in fact represent a different biology to treat by brachytherapy. And then this is kind of an interesting site here where there's these black holes near the stent struts, which are sites of inflammation around the stent struts, in addition to the neointima. So this kind of understanding of the biology that OCT brings us has really made us rethink what are the best ways to treat this. And interestingly, there's some data now from Europe about the relative efficacy of drug-coated balloons. If you look at people who have early in-stent restenosis, and I would posit to you that that's this pattern, which is very homogeneous neointima, they actually don't do as well as late in-stent restenosis, which we describe as neoatherosclerosis. So all of these other patterns, if I can go back to the OCT images, represent new atherosclerosis that is occurring inside the stent. So a later presenting process. And drug-coated balloons probably treat that better than they do that early on. So this is kind of not that big of a database. It's from 4 clinical trials, and it's kind of an amalgam of endpoints, but there's some indication that there may be differential effects depending on the time to treatment. So if I can summarize our view from interventional cardiology, I think this has been and continues to be a very effective treatment for people who have refractory in-stent restenosis. We think it's critical to do this cross-sectional or intercoronary imaging. It helps us understand how well we do at kind of reducing the burden of neointima. And I think OCT is giving us the option of understanding the biology and maybe tailoring our treatment to that. I think, Dr. Roberts and the radiation therapy folks do all the hard thinking. We just kind of put the catheter where they tell us to and let them do the thought process behind the treatment. But I think that the way things are going for us, and particularly with what we've seen by OCT, that the need for brachytherapy in coronary disease is only going to increase. And I'm not confident that drug-coated balloons will be able to manage everything that we have. So that's the end of my presentation. And thank you very much for allowing me to participate in this webinar. I think it's really exciting and great for me.
Excellent. Thank you very much. Next up is Dr. Dehan. He's going to be talking about a range of topics on the physics side, including some specifics about the standard device, QA procedures and calibration, trim management and emergency procedures. He's an assistant professor of therapeutic radiology at Yale as well, completed his PhD in electrical engineering at UCSD and medical physics residency at UCSF before joining Yale. And he'll be talking now about his perspective from the physics side.
Hello, can you hear me now?
Yep.
We can hear you
Right.
and see your slides.
Yeah, okay, so you can see the slides. Thank you for the great introductions. So there's nothing to disclosure, and this is items I'm going to cover for this talk. This is the equipment set. So the IBBT card is set up for the CAD lab, and the physicist will bring this item into the CAD lab. And there are transfer device, and then stopwatches for the measuring dwell time, and detectors for the survey, water and gas bailout box, and the response kit for the emergency source recovery. These are delivery catheter and transfer device. The transfer device includes the radiation source, and then source will be delivered to the treatment lesion through the delivery catheter with the hydraulic pressure. So to deliver the source to the treatment lesions, the delivery catheter need to be attached to the transfer device you can see in here. And also water-filled syringe provide water pressure, and the fluid collection bag collect the returning water. And the gate control switch control the source chamber gate, and then fluid control switch control the water flow directions, which is forward and backward. This is source chamber in the transfer device. So like kind of you can see is kind of that has acrylic windows, and that has you can see the source, which is 40mm source. And then Nova system using the strontium yttrium-90 source, which is pure beta emitting source. The source are enclosed within the stainless coil jacket with 2 radio opaque markers each side, and that each seed length is 2.5mm in length. This shows delivery catheter, and delivery catheter tip has hole for the guide wire pass through, and delivery catheter follow the guide wire to the treatment lesion as a zoom line. The IST wire, which is indicator of source train wire, is already inserted in the delivery catheter when it comes out from the stereo package. So the IST wire provide 3 different functions. The first one is indicating expected source positions when under the fluoroscopy. And number 2 is providing delivery catheter rigidness. And number 3, delivery catheter damage check. So I will explain in later slides. And this is the operation mechanism. So delivery catheter has coaxial dual wall lumens. So when we press the syringe, water will push the source from proximal to the distal directions, and then once the source reach to end of the catheter, there is a mesh structures, and then it blocks the source, and the water can pass through the mesh structure and turn around to the outer lumen, and come back to the device. After end of a treatment, operator flip the fluid control switch, and then that one is making the syringe connect to the outer lumen, water inject to the outer lumen, and the water is once water is reached the end of the tip, and then turn around to the central lumen and pass through the mesh grid structure and push the source, and the source came back to the delivery transfer device. And the one source is back to the transfer device. The operator close the gate, and the source will be kept in the safe positions. And then sorry, like it has the sound. So this is like kind of the showing demo of the source dummy source traveling to the end of the delivery catheter. So you can see in here there's a kind of radio opaque marker and the mesh structures, and the water is passed through. And there are 4 radio opaque markers on the IST wire. So there's one thicker marker, and it is is indicating distal source position, and the other 3 markers indicate 30, 40, and 60 millimeter proximal source positions. So those are gonna helping us to locate the catheter to the target lesions. So once we place a catheter, radiation oncologists move the IST wire back and forward to check any damage of the catheter. So once they moving the IST wire, gonna be feel something on their hand. Once the radiation oncologist is done with the damage test, they will fully retract the IST wire and then engage the delivery catheter to the transfer device. And this is the example of the damaged delivery catheter. We found this damages while the IST wire test, and then we replaced the delivery catheter for completing the treatment. This is fluoroscopy images of the sources placed in the treatment lesion. So, and then after the we see the source, every 30 seconds we took the fluoroscopy images to check the source position. And for the QA procedures, there are a few IAPM guidelines, including TG60 and TG149. And so for this part is we're going to have we have some plan for separate webinar later this year. So maybe I'm not going to touch too much detail for the physics QA part, but let's go over some overview. So the QA checklist is like this. So since the source half-life is more than around 30 years, the source activity is not dramatically changed as other clinical in use sources. So, however, the vendors want to turn back the device every year because in terms of to maintain and adjust the mechanical and the electrical parts. So when we return the current device to the vendor, they will send the other device to us. So that makes us to do the source check, and then we need to do the activity and the source uniformity test. Also, NRC required source leakage test biannually. We collect the fluid from the device and then give to the radiation safety officer, and then they do the leakage test survey. After treatment, we also need before the treatment, we also need to perform the daily QA test. And this is the example of the source certificate from the vendor. And then for doing the source assay, we need the calibrated well chamber and the electrometers. The IBBT well chamber is a little bit different than the the conventional iridium-192 afterloader HDR well chamber. So it's a little bit thinner and a little bit taller, and also has the source holder. So that one is making the sources position at 30, 40, and 60 millimeter source position for the sweet spot. And this is the example of the source assay report. And this is a uniformity test. We using we put the using the GAF chromic film, and then on top we put the catheter and then put the bolus for the buildup, and do the take the image and the scan, and then using the analysis software to find out the differences, uniformity test. And this is the example of the daily QA report, and that this is included, which I mentioned earlier slides. So has the survey matter test, transfer device test, stopwatch test, stopwatch functional test, and documentation check, and then emergency source recovery kit check. And NRC written directive required listed information, and also required the pre and post survey. Written directive includes for all treatment cases. This form is for the general all patients, and then for special procedures such as multi-dual positions, the bifurcation over the hot pullback, NRC require the number of dual position, and then this each the prescription informations. So this is add-on written directives. This document is add-on to the basic one, and then as you see in here, the dual 1 and the dual number 2 or something like that has each injury length and other vessel diameter prescribes those informations, and then we add on this document to the original one. And then the final topic is emergency source recovery. So there are a few common reasons. The first one is move the catheter without the IST wire. So as I mentioned before, IST wire provides stiffness to the delivery catheter. So once we take the IST wire from the delivery catheter for engaging the engaged to the delivery transfer device, the delivery catheter will be too flex, and then it may be like kind of bent if we push the delivery catheter forward without the IST wire. And second and third cases are mainly caused by the friction between the catheter and the sources, like kind of the tortuous vessels, and then hemosmack valve giving like kind of pinching, and then have the sources that has a little bit fractions, more fraction than like normal. And the final one is I'll explain in the later slide. Since strontium, yttrium-90 source is pure beta emitting source, it requires less shielding than the gamma emitting source. About one or 2 centimeter water softened gauze can provide enough the shielding. And then this is the emergency procedure. So there are 2 different scenarios. First one is during sending the source, source is left from the device, but source cannot find at the treatment lesion under the fluoroscopy. Or number 2 case, second scenario is after end of the treatment, source cannot leave from the treatment lesions, or source left from the treatment lesion, but is not coming back into the transfer device. So in that case, at this time, physicists need to start timer to record the extra radiation time. And so those kind of the scenarios, physicians try to move the source forward, backward to overcome any kinkings, or the kind of the like a little bit more the resistance, like to giving a little bit pressure to overcome the resistance. And after a few trials and sources still not moving, we need to decide to perform the bailout. And the bailout, the main bailout procedure is turn on the fluoroscopy. All cath lab steps need to clear from the bailout pass, and the physician retract the catheter using the water with the water soaked gauzes. And physicists need to check the source, observe the monitor, and check the source and the catheter leaving the treatment lesions under the fluoroscopy. And once source is out of the leave the treatment lesions, record the time for the report. And physicists, once we see the like kind of the sources leaving from the treatment lesions, physicists bring the bailout box to the radiation oncologist, and the radiation oncologist pass over the get over device from the cardiologist, and then put the device to the medical physicist. So once they put the device to the bailout box and store the device. And at this time, be careful not to cut the catheter, so make it everything sources within the enclosed system, and then not pinching the catheter with the bailout box, bailout box cover, and then place the bailout box on the physics cart, and then check the device. So this is an example of the like kind of bailout situations, and you can see the kind of the catheter is out of the like kind of the bailout box lid, and then catheter is not cutted, and you can see there's the kind of barely you can see, but the kind of a little bit darker. That one is kind of real source inside of the catheter. And then physicists do the device inspection, and then room survey, and then patient survey. Once all cleared, physicists announce the clear to the leading cath lab staffs, and then cath lab staffs announce to the rest of the staffs. And then after that, the physicists do the follow-up investigation, like kind of the extra dose or the kind of how much dose, and then report to the radiation safety officer. And also like kind of the, if you need it, also talk with the novel spender. This is the example of the source recovery report. And like kind of we like kind of record like kind of the dwell time and like kind of extra time, like how much is expected dose or something like that. And this is other example of the bailout case. So you can see in here like kind of sources within the source container, sources stuck in here, and they kind of never go out. But we try like kind of push forward or like turning back, like sources never move and they're stuck in there. So this is the what I brought like a very early of these emergency procedures. There's number 4 cases, like kind of blue, the kind of sterile bag blue ring is wedged into the between the delivery catheter and then a transfer device. So so we did like bailout, and then we brought the device in the hot lab and then carefully removed the blue ring, and then finally we can get back the source back into the device, the transfer device. Those are our like kind of IBBT team. And thank you very much for inviting us in the webinar. And maybe we have the other topic for Dr. Rovas, I guess.
Yep. Well, we'll be moving on to the final formal presentation, which is done by my colleague in interventional oncology interventional cardiology here at Northwell, Dr. Mirage. He trained at North Shore University Hospital. And then completed fellowship at the Beth-Israel Deaconess Medical Center in Boston. And here he's the director of Cardiac Catheterization Laboratory, and he's going to be talking about integration of brachytherapy into complex percutaneous coronary intervention. And so, yep, and we can see your talk, we can see your slides.
Good afternoon, and thank you very much for the invitation. I've been listening to all your great talks, and hopefully I won't let you guys down with some complex PCI. So I really want to just, I think it's a great follow-up on the great talks that we've heard so far, and I just wanted to go through some of the great complex PCI cases that we can do along with in coordination and collaboration with brachytherapy. So I have no disclosures. So really just to quickly review, what is CHIP? That's this acronym that people have been utilizing all over the place. Just to review, it's complex high-risk interventional procedures. It's a term that was coined a while ago, and really I think most of us are really going out of favor because there are a lot of complex high-risk interventional procedures, but there are also a lot of complex high-risk interventional patients. And I think it's a combination of both. And so the P could be patients, could be procedures, could be a lot of different things. But let's just go right into it. And so this is as you'll see here, you can see a prior stent that looks like calcium, but is calcified as the prior speaker had mentioned. You know, you really don't get stents with calcium in it too quickly, but this was an old stent with a lot of calcium in it and the proximal RCA with progressive disease in the rest of the vessel. And as you can see here in the middle picture, what we decided to do is we placed an Impella, which is a percutaneous left ventricular assist device, and supported the patient. The person also had left-sided disease, but for the sake of this talk, I'm just going to show you the right. And you can see here we used an atherectomy device. So this particular case we utilized rotational atherectomy to actually burr out the calcium that existed and potentially even part of the stent. In doing so, we got rid of the in-stent restenosis, and we went ahead, and you see on the top right picture, fixed the entire vessel and got a very good result and got flow back. This was actually a case of an old bare metal stent that was placed 20 years ago that actually had brachytherapy done to it immediately after with ISR, and the patient had been lost to follow-up from a cardiology interventional group for about 15 years, and then came back and had this. So a case example of what we can do in the interventional lab, and luckily this person actually has, with drug-eluting stents, has actually held up very nicely and has not had any restenosis or new symptoms, so hasn't required brachytherapy as of yet. But that's not always the case. So, you know, we have all these different calcified lesions, and we do a lot of stents in a lot of patients. And fortunately, with image guidance, you know, our in-stent restenosis rates have gone down. However, they're still not zero, and we still need to utilize brachytherapy the best way we can. I just wanted to review some tools. As I mentioned earlier, we showed you the rotoblator case with its rotational atherectomy. This particular case is orbital atherectomy, different type of atherectomy, and different types of tools we have in our tool belt to be able to treat calcified coronary disease. We published our outcomes on this in 2018 and amongst high-risk cases, and showed really the two atherectomy devices were pretty equivalent to most of their outcomes. And we have a new kid on the block, and the reason I bring all this up is that this is something that we're using more and more in our brachytherapy cases. So I thought it would be good to present this to the audience. It's something called intravascular lithotripsy. It's essentially a balloon with electronic sensors, and you can see here's an unfocused electronic sensor. It's an emitter. It's within a fluid-filled coupler, and electrical energy is emitted, and it creates these bubbles and expands and collapses, creating sonic pressure waves. It essentially works the way you would imagine lithotripsy works, except it works in a calcified coronary artery. And in doing so, we're able to, and I'll skip over this, we're able to treat vessels like this, where you can see here, there's a prior stent in this LAD, and you can see here there's a lot of both some neoatherosclerosis, but also calcium from behind the stent. And that could have been just from maybe inadequate vessel prep prior to the stent being placed, or a development of calcium after the stent was placed. But cases like this, where I showed you a case where there was a very old stent where we did rotational atherectomy, in a vessel like this, which has some tortuosity that has its interventional limitations. And so the feeling in this particular case was, let's try a balloon angioplasty, which is what we would normally do. And you can see here with non-compliant balloons, we were unable to completely expand the stent. We tried expanding the stent, using multiple non-compliant, very high pressure balloons, and really were unable to do it. So we went ahead and used lithotripsy, and you can see here with the lithotripsy, good expansion of the stent. The calcium behind the vessel actually was fractured, allowing the stent to expand more adequately and more optimally. And really, we were able to do a better job. This particular patient ended up coming back, and we ended up doing brachytherapy on this patient because there was enough intimal hyperplasia in the stented area itself that we felt that instead of placing another stent, brachytherapy would be a good choice, even just with one stent, one drug-eluting stent being placed. As you can see here, final luminal, and using OCT, final luminal diameter was about 4, not perfect, but very optimal, and someone who I think that will do very well. We know that incidence in restenosis is very prevalent in the United States. This is old data, but this hasn't really changed that much. You can see here, overall incident restenosis, whether it's DES or non-DES, is quite high. We were fortunate as well as around the same time as Samin Sharma's Sinai group had published, we published our own 250 patients, experience on brachytherapy, and we really showed that, no matter what type of device we use, whether it's cutting balloons, angiosculpt, rotational atherectomy, a combination of laser atherectomy and otherwise, we really had a pretty reasonable result. You can see here, instant restenosis at 1 and 2 year follow-up was pretty low. Stroke rates were very low. Also, all-cause mortality was low, and myocardial infarction rates were also very low. So, we showed here that safe and effective method, even in treating very complex lesions, and we were able to, and we're continuing to treat patients like this. Another case, one example I wanted to show you is that this was a patient who I did in 2021 who had a left main LAD bifurcation, ended up doing kissing DK crush stents. And the result came out great. Again, image guided, very optimal TCI. However, the patient had all the risk factors in the world: diabetes, overweight, high cholesterol. And within a year, the patient came back with restenosis of the left main LAD and milder restenosis of the circumflex. Required at the time, actually, cutting balloon angioplasty, more optimal balloon angioplasty, and subsequent brachytherapy, all at the same sitting, to really restore their left main bifurcation. Unfortunately, the patient was not a bypass candidate, so we really had to do everything we could in the percutaneous fashion. But another case example of a very high-risk anatomy, very complex anatomy, and our ability to do brachytherapy. This patient actually has done very well since their brachytherapy treatment. Of course, we're treating their risk factors very aggressively, to hopefully reduce the likelihood of them having restenosis. And this is a case of that I did actually 6 months ago. You can see here, this is a patient with a stent jacket and an entire RCA with a CTO at the distal vessel. You can see here with the retrograde injections, you can see here that there's just flow in the distal RCA, but the entire RCA, probably over 100 millimeters of length of the vessel, was stented, and just the distal part of it was not stented but still occluded. We went ahead and opened it up, and you'll see here, this is after the initial CTO PCI. We opened up the vessel, got great flow down to the distal RCA, and we left this patient to see if this optimal PCI would really hold. Fortunately, within 6 months, the patient came back. We reshot the coronaries, and you can see here again the collaterals to the right system are back, and the RCA is pretty much closed all the way to the ostium again. So this is a angiogram I did last week. And actually, this patient is going to come back from a repeat CTO PCI and brachytherapy this time to his RCA to try to reduce the likelihood of this happening. So this is something that maybe in a future meeting we'll be able to show this, but I think these are great case examples of what we can do in terms of complex high-risk PCI, the successes we've had, and some of the failures we've had, and how we can try to make things better moving forward. But thank you very much for your time. Thank you very much for the invitation. I hope I was able to provide some interesting chip cases to you. And if there's any questions, I'm happy to answer them.
Excellent. Thank you very much. So if everyone can kind of turn on their microphone now, because we just have a few questions that to address that were brought up in the Q&A. One of the questions that folks wanted to answer live was basically the treatment margins. How far you go on either side of the injury area. So if there's a standard that people use, I know that there's a little bit of a variety on that one. Is there a margin that we treat proximally and distally to the in-stent restenosis?
Yeah, I mean, 5 to 10 millimeter margin is what's required, and there's some data showing that you have a high risk of marginal recurrence without the appropriate margin. So when possible, 10 millimeter margin is ideal.
Yeah, they call it like the candy wrapper phenomena. If you look at like a roll of lifesavers, exactly. And then there's another question about retreatment of the same area if restenosis occurs after one treatment, and that was one thing. Another one that I think Dr. Pfau wanted to answer live.
Yeah, I think it's important I wanted to hear Dr. Devlin's take on this. We've had our program only open for a few years, and as Ken said, we're just over 200 cases. We've probably had 3 or 4 retreatments, but I'd be interested in Dr. Devlin's perspective on that. In terms of retreatment.
So the other one question that was in there that I think goes with this one is risks of side effects. I always teach the patients that there is an innocent bystander. The innocent bystander is the endothelium. The endothelium is this soft, beautiful tissue that's there. Nobody needs to treat it, but we beat the tar out of it, left, right, and center. So it takes time to heal. And as it's healing, there's the potential for a blood clot. And there were various studies back that showed that, long-term dual antiplatelet therapy, classically Plavix and aspirin, were a safe way to do this. And so if we look at the retreatment, we can do the retreatment, and we do successfully without toxicity, providing we've totally sold them on the dual antiplatelet therapy. And so we think the issue is endothelium. We think the risk is of accumulating an acute clot because of the endothelium healing, and we think the antidote is perpetual DAPT, is how we look at it. There is one datum from way back when, which is known as the Condata aneurysm, where there was a single use of iridium in a vessel, and it was seen on the angiogram to be right against the ostium, I think it was, of somebody's LAD or main, and they got an aneurysm. So they put a stent in the vessel where the aneurysm was, and the guy's probably still alive 25 years later. So it's sort of like the worry that we would cause aneurysms routinely for what happens is not supported by data, as far as I know. And so I think that in our hands, with my anecdotes, if we have 100 patients, 75 of those will be managed with brachytherapy. But then the 25, what do we do with those people? We do bring them back. We do the PCI, just like Dr. Miraj was describing, and we'll do all the things you did, and I'm sure, and then we'll absolutely reinforce the antiplatelet therapy, and we go on. We haven't had major adverse coronary event from that, and we are watching these patients on a registry.
Mm-hmm.
And Dr. Devlin,
and we also feel more comfortable if there is say a 9-month interval between the 2 brachytherapies. Longer is better.
And all repeat radiation therapy across the globe.
Yeah, exactly. I've never done a 3rd brachytherapy, but
I have.
Yeah.
Dr. Pfau, you had a different question.
No, Ken brought it up. I just wanted to know what you felt about the interval between treatments.
Yeah, long is good, right? So Dr. Han, I really enjoyed your presentation. Most people don't like physics presentations, but you made it hugely interesting, and especially when you're doing the bailout issue. And I totally love that. Now, one of the things, I was visiting Professor Samuel recently, and I actually observed, I just asked them, I was doing skin cancer, by the way. And so I just asked them, what about testing the catheter during each case. So as you know, you've got a blue nozzle, you put on a syringe of water, and you should test it. Now, the question I have for the team, almost if you can raise your hand or something, do you all test each catheter before you use it, like you thumbs up, thumbs down, or not? Because what I like to teach, and this is good for the people listening, that test is life and death. If you happen to have a leak in the distal catheter, the 16 sources are not radiopaque. They spray out, and it's such a high activity, it would be a fatal event. And yet, when I have traveled around places, I worry that everybody's not fastidiously testing it. So in our safety timeout, and on our sheet, which is very close to your sheet, Dr. Hahn, which I'm very impressed with, including the bifurcation geometry and the pullback geometry. I love it, love all that stuff. So, but are we checking that we did the monthly QA test on the machinery, but that each individual catheter is hand tested ahead?
Yeah, I'd say that for our practice, we don't, inspect the catheter with any, additional, procedure. But once the catheter is placed in the patient, the stylet is moved in and out to make sure there's no undue resistance, and that you're going to be able to deliver the sources. You attach the catheter then to the device. You pay a lot of attention to make sure you don't have the plastic bag getting in the way of the junction of the catheter and the transfer device, because that's a major pitfall. And then you just squeeze the syringe gently and make sure you have appropriate resistance. If you're able to really push water through the system, there's a leak somewhere.
Right. So but that leak should be discovered before the isotope goes down, right? Yeah. And I was truly surprised that it wasn't. And just checking with everybody that is life and death. The only other thing you could do was, I don't know, dissect or cause a huge perf or something like that. There's very few things you can cause when you're on a wire. But that happens to be the fatal one, which nobody's seen so far. But it is in my heart to make sure that everybody's doing it.
The most common pitfall is the bag getting caught in the connection. And then the other pitfall is once the stylet comes out, if there's pushing the treatment catheter forward in the coronary artery, it's so flimsy at that point.
Right.
That's where we sometimes get into a kink.
So I agree with you 100%. And I in the cath lab, as partnering with my cardiologists, we really hand on the Bible that you're not going to move this again. So that if you put it distal and you can get it distal enough, you can pull it back safely, no harm, no foul. But the push forward, about half the time will kink the dang thing. And even and half of that time, you do have to do the bailout. Sometimes you get away with it. But the bailout, I love your description. Is a perfect description of it. I would do the inspection of the catheter outside the room, back in the hot lab. I just throw them, physicist and box out. It's sort of like so that there's not the worry of the staff around you that you're exposing them. That's just as a, so what? That's like rearranging the flowers for dinner,
Yeah.
All right.
Yeah, the pressure testing it's an excellent, it's a very good practice. It definitely helps you avoid a lot of very unpleasant surprises during the case. And so it's a good idea.
Am I allowed to make a reimbursement comment? So Dr. Fowl, we really raised, and Dr. Roberts, a really beautiful idea. We went to the hospital with this proposition that sure enough, the money for the spot thing of pro and tech for this is very low and absolutely ridiculous. But like both of you alluded to, being a regional center, you're bringing not only that business, we did an assay of a year, and we saw that the range of the full tech point of service of the event of a 23-hour admit with possibly an ICU admit and all the rest of it was such that it really did justify the presence. And what we were able to do is we didn't say we want a piece of the pie, but we wanted attribution that we contributed equally as everybody else did. to that and how they're assessing contribution to the various budget levels. And it's a political conversation which we share with the administrative leaders across the departments. But that's our piece that we've made with the money, and that's the way to go, is to say that we're bringing whatever large amount of money to you because they've got everything else except they don't have the brachytherapy.
Right. Yeah, for our purposes, probably reflecting a large disorganization with understanding financial flows, we don't get into any discussions with internal
Right.
money flows to justify our program. It's really we think it's an important part of what we bring to the table, and probably
Right.
our oncology practice subsidizes the cardiology business, honestly.
Yeah, for sure. But, I'd just like to raise one other thing.
But it is this is something that brings more business to the cath lab from outside of our network. And the other thing I would say for the radiation oncology team is you have to be prepared to understand that you're going to consult on patients who end up not needing brachytherapy, and that's an okay thing for the program. And probably it's a marker of a quality of the program that some of the cases that you consult on turn out to not require brachytherapy, but it's helping out your cardiology partners.
I just want to one more quickie with Dr. So the issue of where you position the distal position, the second dwell of a pullback. What we've done is hokey, but it's very effective. We take a magic marker pen. We tell nobody to move the table or the angle of the gantry, and we then watch on exhalation, not inhalation. We watch where it sort of bounces. We allow a 5 millimeter gap, and we pull back. Not to the 5, but to about 7 or 8, because once you let go of the catheter, it will elastically bring the last 2-3 millimeters again. So we tend to ink the screen, and then we don't take it to the mark and let it get there on its own. It's quite fascinating, but it's just to say that the last thing you want to do is you've left a 2 millimeter gap, and now you're pushing it forward. Then you've got a bailout.
Yeah.
I got yelled at when I inked the screen in the interventional cardiology lab. So now we keep a little piece of tape. So that does not get me in trouble for putting marks on the screen. But yeah, that was it looks, I don't think we'll have time to go over the cases, but that pullback. So what Dr. Devlin was mentioning, for those who are still listening on the attendees, it's like there's a 40 millimeter train and a 60 millimeter train, but often you may have a lesion that is much longer than that. So the hot pullback is your way of covering a longer segment. And so, and Dr. Roberts had talked about it a little bit in his talk as well. But you treat your first segment and you pull back and you leave yourself that little gap. You could overlap. There people have overlapped as well, up to 10 millimeters or even more. Those vessels are incredibly powerful. They can take a huge amount of dose. And so if there's overlap, you shouldn't be concerned that you delivered a misadministration or anything like that. And so, but making sure that you account for it is very key. And I really liked your documentation for the hot pullback. And I may be reaching out to you afterwards to see if we can try to steal some of that as well, because we haven't incorporated that yet in our own practice.
Super.
So, is there anybody who you would not treat with cardiac brachytherapy? Are there cases where you would just say, no, this is not, you have an in-stent restenosis, they've had a DS, like who do you not treat?
The only example I can give of us saying thanks but no thanks was a 40-year-old male who was otherwise healthy, and he had 2 layers of stent in his proximal LAD. And in my mind, I think there's no reason that person shouldn't have had bypass surgery with a lima to the LAD. So he was referred to us from one of our non-network providers, and we haven't heard back from that particular provider since we turned that patient down. But I do think for the patient's sake, that's the right thing to do. That's a really durable, long-term cure for that type of disease, to put a lima on that. normal LV function, otherwise healthy person. And, you know, brachytherapy is good, but it's not as good as an internal mammary graft. So that's the only time I can remember saying that we should not treat that patient with radiation.
So Dr. Maraj obviously told about the use, it looked like routine use of the impeller, which I completely agree with and love. But there comes a point where people are too sick or too tortuous, such that the thing called a 6-minute dwell in your LAD is likely a hugely high-risk behavior. And we've had a few people who ST you know, really decompensated on the table down the years. And I think that we'd be a little more careful, you know, and thoughtful about that. What are the goals of care? Are we in a sort of palliative mode, or are we in a definitive mode, is how I would think about that.
And one last open question that was on the Q&A: how much time do you set aside on the RADONC schedule for procedure? I put arbitrarily 1 hour per case. So if I've got 5 cases scheduled, you know, they block a whole morning for me. And so, but you know, how do you manage your time?
Well, we have cases that only occur 1 day a week on Wednesdays, and so I just I know in advance how many cases we have. And I just, the whole day is devoted to coronary brachy, and when I'm idling, I'm working on other things, you know, treatment planning for our cancer patients and academic stuff. So it's just that's how I manage time. Just dedicate a day to this service.
So we have Tuesdays and Thursdays. To get the baseline is 2 cases each day in just one room. We've got 5 rooms that run. I at the same time can do radio embo right next door in interventional radiology. I can do skin cancer, brachytherapy down the hall, and everybody just knows that you may have to wait for 3 or 4 minutes till Philip finishes the last thing he did. And so in the course of the day, there may be 12 patient events, 2 to 3 of which may be cardiac, and that's twice a week.
Yeah, we've got one situation where we have multiple interventional cardiologists credentialed, so they'll actually be set up in like 3 different rooms, and so you can bounce from room to room too. So that is also a really nice way of maximizing your productivity and taking care of a lot of patients quickly.
Right, and in the old days when we had loads and loads of bare metal stents, and there were 4 or 5 rooms running at the Brigham, and you know, on a windy Friday, you might get 8 or 10 cases where you had all these famous people who were doing their interventions and so forth. So you literally stay there, keep the lead on, and just, you know, have a donut or something between cases, and you do lots and lots of cases for sure.
Yeah, that's the
good
key.
days, Dr. Pfau, huh?
Yeah. Coordination with your interventional cardiology partners is absolutely critical. I mean, if you work it out right, and if you stack the cases properly, you can be very time efficient, and you can really kind of maximize your efficiency during these days.
Yes. Good words.
Yeah. Let's see.
All right. Well, thanks.
So we've gone a little bit over. And fortunately, I think the case presentations that were incorporated during the other talks have helped us address some of the really the complex situations that we can come into. But you know, I thank all the attendees for joining us today. This will be recorded, so we'll be able to share it with all the EBS membership in perpetuity going forward. So all of our words are saved, and so hopefully none of us said something too embarrassing. And thank you to all the panelists for joining in and contributing contributing to the education of our specialty and talking about this really great procedure that has incredible impact on patient lives.
Thank you.
Thank you.
Thanks.
Thank you.